Good morning, everyone. I like to thank my wonderful mentor at ECU, Dr. Thank you. Sorry. Dr. Robertson for her support in this project. I like to acknowledge Duke UNC ADRC for the funding, and I don't have any other financial disclosure. As we all know, some of this background regarding people living with Alzheimer's and related dementias and their caregivers, I would like to point out that what motivated me for this project was to promote the participation of people living with ADRD and their caregivers in healthcare research or health services, public health research, so that we better understand what matters for them, their daily life experiences, and that would help us to make sure that they will receive adequate support and services and being able to live in the community with highest possible quality of life for a longer period of time. And being in the Eastern North Carolina, also another added opportunity to sort of engage individuals from across racial minority groups. So with that, my Rex Scholar project had three big objectives, using the mixed method approach, as I just mentioned, to better understand the lived experiences of people living with ADRD, their preferences for long-term care, and also their planning with their family member regarding their need for long-term care, how it can be served in the future, and their experiences of communicating with the healthcare providers during the disease process, to starting from receiving the diagnosis and future care. So the first aim for this project was to sort of explore the health and well-being profiles for both people living with ADRD and their caregivers, and those measures include both physical, mental, and psychosocial health outcomes, and to do the qualitative interviews with talking with them, people living with ADRD, to sort of learn how their daily living experiences. The second aim was to explore the association, if any. We all know that dementia caregiving is very stressful, burdensome for caregivers, and how that linked to their psychosocial outcomes on health, such as life satisfaction or their emotional well-being. And finally, to know sort of their long-term care planning, how they are planning for their long-term care from the financing perspective, from the caregiving support as well. So in order to recruit those living with ADRD, we use the short portable mental status questionnaire, which basically allow us to exclude those who are far away in the disease process, meaning to exclude those who are have severe dementia, because we wanted to make sure that they are able to complete the survey and also to be able to participate in the qualitative interviews. So in terms of our recruitment method, so we used multiple recruitment resources, including both the clinic, where at ECU we use the geriatric clinic, and from the community perspective, we use the Council on Aging, AAAs, and other community-based dementia support groups, and as well as the NC Brain Health Registry. So our recruitment is still ongoing. So far, we have 18 individuals who completed the survey for the ADRD, and 6 of them are from the clinic and 12 from the community. And 7 of those community participants also participated in the qualitative interviews. So far, we have 27 caregivers recruited, and we received 22 completed surveys from them. Here's some of the basic demographics that I'm showing from the participants from the community side. And so majority of them, they did mention that they received their diagnosis from the neurologist. And the reason that we haven't been able to enter the all 12 data so far. And they do have some limitation in their activities of daily living. And the one thing also, I forgot to include on this slide is that all of them did mention that they wanted their long-term care in home, not any sort of residential care settings. So that's their preference for the future. The reason I'm not able to show today the clinic participant result, and I sort of label it as a warning. So although our survey we thought it's an anonymous because there was no identifiers that would allow us to link the survey responses to the EHR for the patient, those who were selected from the pet clinic. However, we just learned that a couple of weeks back before, because the survey included age, county, and zip code, and those 6 patients filled out the survey sitting inside the clinic facility, they are considered as a HIPAA identifiers, and we had to collect their HIPAA form signed. So I just want to share that experience with all of you, that if you are doing this type of research, and we usually thought that age as a demographic field, so that's not an HIPAA identifier, right? But here the concern was that because this filled out the survey sitting inside the clinic. Had they filled out the survey just outside the main entrance of the clinic, that was not considered as an HIPAA identifier. So we just learned it. So we are just in process of sending them now. I do have their address on the consent form. So I will be sending the forms to them, mailing with the hope that they will sign it and send it back to me. Because although the number seemed like only 6, but I probably spent more than 20 hours in the clinic to recruit those 6 participants. So I do want to use their information in my study. So here's some of the caregivers' characteristics, but for the sake of time, I'm not sort of talk about those. But I do have the posters, and I'll be happy to share more details. But one aspect of caregiving that I would like to note here, that we all know that caregiving is a choice, right? So people make the choice for different reasons. So I wanted to know in this survey that what are their choices, that why someone became the caregiver. So I included a survey question asking them, why did you make the choice to be a caregiver? Whether you felt like it is your duty or it's free choice, or you became a caregiver because no one else was available, or you don't have the financial resources to get the care from the market. So as we can see that, so of course they are not mutually exclusive, so caregivers could choose more than one option, and all of them said that they became caregiver because they felt like that's their duty to their loved ones, and of course their free choice. But some also mentioned that about 1/4 that they didn't have the financial resources to get the care that their loved one needs from someone outside and pay for the care. So we are still learning. There are many challenges and opportunities also for the recruiting, as we know that this is a very challenging population to reach and recruit them in the study, this type of healthcare research. So basically the keeping multiple recruitment method is logistically it's challenging to sort of keep track of those multiple recruitment strategies. And as I just mentioned, clinic recruitment is very time intensive, and patients sometimes even though they are willing to participate at the beginning of their visit, but they just don't want to wait as they finish their visit with their clinician. And so that's definitely it's a challenge, but then also, communicating all the different types of community resources, community groups to to make the schedule and everything. So that's definitely is another challenge. But it does also offer some opportunities as well, because it helped us to learn also what works best for this population to recruit them. And for example, the survey mode, what type of survey mode, whether the paper survey or the survey link that work best to get the recruitment number. The interesting part also, as I just mentioned, is the mixed method studies. So the qualitative interviews that we are interested in, talking with people living with dementia. And we sort of had our 4 big umbrella questions. The first, we started with what activities do really matter for them? What's their daily activities? And do they feel like their daily life has changed before and after their dementia diagnosis? And the second sort of theme was their experiences with healthcare providers, the time they received the diagnosis and beyond. And then what's their preferences for receiving their long-term care. And finally, as an open-ended question for them, how they want their voices to be heard from among the research community, their healthcare providers, or whatever they would like to share with us. So we individually, both myself and Dr. Robertson, we individually analyzed the transcription, verbatim transcription from all those qualitative interviews line by line, and then we came up with some sort of big themes that those participants shared with us. So first was meaningful activities. Almost all of them shared that, well, they are trying to do everything that they like and they used to do before their dementia diagnosis. The diagnosis does not change their perspective, how they live their life, and their daily life activities. Like they do want to physical exercise and they do it, hobbies and interacting with peers and things like that. The second theme was the healthcare providers. All of them shared that their experience with communication with the healthcare providers not very positive. They felt like they are ignored. Their symptoms, their questions are not being addressed during the clinic visit, and they offered very few resources. They just got the diagnosis and that's it. And they got puzzled that what to go next and what to do. And they didn't feel like they were explained enough the disease process, what to expect, and things like that. They do want to live their life with the fullest capacity, knowing that this disease, it is an irreversible process, but they still want to live the quality life, being at home, but also feel like they would like to have more information to make informed decision. And finally, they do worry about the long-term care, how to manage them, and also the caregiver support, because they understand that this is a burden for the family to the care that they need, and this burden is always on their family members, and there isn't financial challenges. Some of them, they had to quit their job due to the disease, and their caregivers also had to do the same. And they are concerned about the long-term care cost and what to do with that in the future. So definitely, we are still learning, and some of those lessons that we learned, yes, one way the clinic recruitment, we feel like we know the confirmed dementia diagnosis from their EHR, but as I just mentioned, it's really time-intensive, and make sure that HIPAA waivers are being signed by the participant, given the fact that where they are physically filling out the survey. And community recruitment also, it's an online support groups. It's an so far we felt like Dementia Minds. We have the higher number of individuals participant from that group. But for the caregivers recruitment, some community events worked best, like Senior Centers, Council on Aging, or AAA, when they offered those type of workshop and group for the caregivers. And the research registry finally, but it's limited to the research, the research team, the access to the research registry. So with that, I want to thank you all for listening, but I'm grateful to all the participants that so far participated in our study and contributed their experience and insightful experiences living with the disease and their caregivers. Thank you very much.